Hello and welcome to Learning EMG. In this video series, we're going to review the clinical and electrodiagnostic features of the most common neuromuscular disorders. If you find our channel informative and helpful, please do subscribe and do not forget to hit the bell icon to be the first to watch our videos. In this video, we're going to review the findings of ulnar nerve lesion at the elbow. Let's dive in. Ulnar nerve entrapment at the elbow is the second most nerve entrapment syndrome in the upper limb after carpal tunnel syndrome. Patients with ulnar nerve lesion at the elbow primarily present with progressive numbness, tingling, and pain over the distribution of the ulnar nerve in the head. Symptoms are typically exacerbated by prolonged periods of elbow flexion, such as sleeping with the arms tucked under the pillow, or by activities that require prolonged elbow flexion. In most patients, sensory complaints are the initial symptoms. With prolonged and excessive nerve operation, weakness of the ulnar innervated muscles may develop. Patients may develop atrophy of the head interesting muscles and muscle dexterity. As the weakness progresses, variable degrees of ulnar clawing hand or ulnar claw deformity may develop. Ulnar claw hand is characterized by the tendency of the fourth and fifth fingers to flex when the patient is asked to extend the fingers. This is ulnar claw hand. This can be seen in figure 1-18 of the book. Ulnar nerve palsy can cause an over-abducted positioning of the fifth finger, and patients may note that the fifth finger gets caught when placing the hand inside a pocket. This is known as Waterberg's sign. This can be seen in figure 1-19 of the book. The Tinel's test. The Tinel's test, which is performed by tapping the ulnar nerve at the elbow, may elicit a pins and needles sensation along the medial forearm extending to the fourth and fifth fingers of the hand. This test is, however, a non-specific test because this test can be elicited in individuals without documented ulnar nerve lesions. Strength testing may demonstrate weakness of fingers abduction, weakness of fingers adduction, weakness of thumb adduction, and weakness of the interosseous muscles. Delays in the detection of ulnar nerve compression may lead to significant weakness and atrophy of the hypocliniar and interosseous muscles. The Froment sign. The Froment sign is also frequently positive and indicates weakness of adductor glossus. The Froment sign is shown in figure 1-20 of the book. With respect to sensory examinations, with ulnar nerve entrapment at the elbow, sensory loss may involve the entire sensory distribution of the ulnar nerve in the head. The area of sensory loss involves the distribution of the ulnar nerve at the palmar side of the hand and the distribution of the ulnar nerve at the dorsum of the hand related to the dorsal ulnar cutaneous nerve. This is because that the lesion is proximal to take off the dorsal ulnar cutaneous nerve that innervates the dorsum of the hand. Done. Let's review the electrodiagnostic findings in patients with ulnar neuropathy at the elbow. With respect to sensory nerve conduction studies, there are two abnormal slabs in patients with ulnar nerve lesion at the elbow. First, the slab to the ulnar nerve recording the digit 5, and second, the slab to the ulnar nerve recording the dorsal ulnar cutaneous distribution over the dorsum of the hand. The DUC or dorsal ulnar cutaneous nerve slab is expected to be abnormal in patients with ulnar nerve entrapment at the elbow. As I said before, the reason is that the lesion is proximal to the takeoff the DUC branch from the distal forearm. Please note that these slabs are expected to be low amplitude or absent in axonal lesions of the ulnar nerve at the elbow. But in pure demyelinating lesions, these slabs may be preserved. Okay, now, what are the normal slabs in patients with ulnar neuropathy? An important slab to test that is normal in patients with ulnar neuropathy is the MAC slab. The MAC or medial antebrachial cutaneous slab is expected to be normal in patients with ulnar nerve injury. This step is used to distinguish between a ulnar nerve injury and the lower brachial plexopathy. As you know, in lower brachial plexopathy, for example, in the lower trunk lesions or in medial cone lesions, the MAC step is expected to be abnormal. However, in patients with ulnar neuropathy, this step is expected to be normal. With respect to motor nerve conduction studies, there are some features that point to a focal demyelinating lesion of the ulnar nerve at the elbow. Let's review them. First, if the absolute motor nerve conduction velocity in the segment above the elbow to below the elbow is lower than 50 meters per second, this may indicate a focal demyelinating lesion of the ulnar nerve at the elbow. Second, if the NCD of the above the elbow to below the elbow segment is greater than 10 meters per second slower than the below the elbow to wrist segment, this may also indicate a focal nerve entrapment at the elbow. Finally, a conduction block of the ulnar nerve at the elbow can be demonstrated by a drop in the Cmax amplitude of the ADM or FDR with ulnar nerve stimulation above the elbow when compared to ulnar nerve stimulation below the elbow. This is shown in figure 1-22 of the book. Please note that in patients with a normal or non-motor response from the ADA, recording from FDR should be performed. I mean, a normal study of the ADM does not rule out a ulnar nerve entrapment at the elbow, so you should record the FDR as well. Okay, finally, let's review the needle EMG examination. What are muscles with abnormal EMG studies in patients with ulnar nerve entrapment at the elbow, I mean in axonal lesions? First, the ulnar innervated muscles of the forearm, including the FDP to the fifth and fourth finger, and the ulnar innervated muscles of the hand, including the ADM and FDI, are expected to be abnormal in patients with ulnar neuropathy at the elbow. But please remember that the FCO muscle, flexor carpi ulnaris, may be preserved in some cases of ulnar nerve entrapment at the elbow. So, the lack of EMG abnormality in the FCU in no way excludes an ulnar nerve entrapment at the elbow. And finally, we will review the muscles with normal EMG studies in patients with ulnar neuropathy. First, remember that all median innervated muscles, including the FCR, the FPL, the abductor pollicis brevis, the pronator tres, are expected to be normal. Second, the radial innervated muscles, for example, the extensor indicis, the extensor pollicis, are expected to be normal. And please note that normal EMG study of the C8 and T1 innervated muscles, for example, the abductor pollicis brevis or extensor indicis, are crucial for ruling out a lower trunk plexopathy. Normal EMG study of the C8-T1 innervated muscles, including the APB and EIP, are helpful in distinguishing a lower trunk plexopathy or medial cord plexopathy from an isolated ulnar nerve lesion. Okay, in this video we review the clinical and electrodiagnostic findings of ulnar nerve lesion at the elbow. We have gathered a summary of the clinical and electrodiagnostic findings of the most common neuromuscular disorders in this pocket book entitled Summary of Electrodiagnostic Medicine. This book is available on Amazon.com, and you can hit the link below in the description to see the book page on Amazon website. Also, if you are interested in studying real cases related to ulnar nerve lesion, you will find our other book, the case studies in electrodiagnostic medicine, helpful. In this book, we have included real cases of ulnar nerve injury at the elbow and ulnar nerve injury at the wrist, and we have discussed the clinical and electrophysiologic approaches to these patients. Hope to see you soon with another summary video. Take care and goodbye.